Okay. Good evening, everyone. Thank you very much for joining us again for the clinical care platform. Today we have a number of guests, and we look forward to today's topic. Today's topic is psychosocial impact of COVID-19. And we have a panel which would be introduced shortly to you, which are going to lead us in terms of unpacking this particular topic. I just want to say that to appreciate the work that, health workers and the society, what we have been doing in the last 5 to 6 months. It's actually exciting, at this point in time to see cases of COVID being reduced on a day-by-day basis. We have seen a reduction in admissions. The number of patients who actually require high care, ICU care, has significantly been reduced. And I actually reviewed the recent report by the MRC looking at all natural deaths in the country, including excess deaths. And we are starting to see also a significant drop in deaths in the country. There's also a public health measure, the RO, which actually measures, the number of secondary cases that you would get, from one person who becomes infected. If you look at that specific measure, around April or so, for every case, we would get 2 additional positive cases on average. That has also been reduced to 1, so that sort of confirms that the transmission levels at community level has also reduced. Obviously, we take this information with caution, and we want to continue to ensure that public health interventions, are implemented. But what we know is that as the cases get reduced, the psychosocial impact, especially the mental health of health workers and the community at large, would remain a problem that we have to deal with for the next, I don't know how many years. So today's topic is very important. And on that note, I would like to say, before I introduce Dr. Segole, just to say that remember that these meetings are CPD accredited. Those who attended last week's meeting, certificates are due to be released tomorrow. So please, on the chat box, do type in your full name, your email address, and also your council registration number if you are a health professional. At this point in time, I'm going to introduce Dr. Joshua Sekole, who is the ENT head at Witbank Hospital, but also the command lead for COVID response in Nkangala district, specifically for Witbank Hospital. Dr. Sekole, are you there?
Thank you, Dr. Mawela. Good evening, colleagues, or should I say good afternoon. Thank you, Dr. Mawela and the province again for the platform provided. This platform in the past weeks have provided healthcare workers to share information, experiences, and to educate in relation to COVID-19. And we hope this platform continues even beyond COVID-19. This evening again, we continue to share our knowledge. And the topic for today, like you have said, it's psychosocial issues or impact in COVID-19. In general, psychosocial issues pose a challenge to everyone, communities, healthcare workers, families, patients, by mere virtue that it's not a physical illness, but something you cannot see, mental. So it tends not to be taken serious, especially if it's something that you cannot see. In the panel of discussion of recovered healthcare worker in the previous meetings, issues of anxiety, depression, stress, while one is in isolation were alluded to. So I'm picking it for us this evening. It's my guest. I've got 3 guest speakers, and then I've got few in commentary. So first, to give us a whole overview, as a main guest speaker, it's Dr. Nkwane, who is the head of psychiatry in Witbank Hospital and Mpumalanga as a province, and also part of the COVID command team, which I lead in Nkankara district, as well as the province. In commentary to support Dr. Nkwane, this is quite a big one. It's Dr. Moleleke Nsutunza. She is a principal clinical psychology in both public institution and in private practice. She has been practicing as a clinical psychologist for 10 years. She was conferred her doctoral degree in psychology, PhD psychology from University of South Africa, and she was awarded a Master of Science degree in psychology, MSc psychology from University of Limpopo, Medunsa campus. She obtained a Bachelor of Psychology degree from University of Transkei in Nitra, and she has interest in health psychology / medical psychology with focus on genetic disorder. And then of important, which is relevant to today, is that she's currently embarking on a COVID-19 related research. Dr. Mawela, I think you need to reach to her since you are also leading a research in the province. Our second guest speaker, it's Dr. Lerato Dikobe Kalani, born and raised in Diepkloof, completed MBCHB at Medunsa in 1999, and completed her MMed in psychiatry at University of Pretoria 2006. She headed the Department of Psychiatry in Pretoria Academic Hospital, known as Steve Biko currently, from 2006 to 2007, went into full-time practice in 2007 to date. She is passionate about psychoeducation, transcultural psychiatry, and managing to balance career and family very well with 5 children and a happy husband. Colleagues, without any further ado, please let's welcome our guests, and hopefully this is going to be a very interesting and exciting topic. And let's call upon our first speaker, Dr. Nkwane. Please take us through. Thank you.
Thank you, sir. Good afternoon, colleagues. This is Dr. Nkwane. Dr. Skole introduced me. Tonight we'll be talking about the psychosocial impact of COVID-19. Yeah. Okay. How do? Okay. I need assistance. I want to move to the next.
There we go. Let's go.
Thank you.
We can see your second slide.
Yes, I can see that. Yes. All right. So these are the things that we're going to look into. It will be introduction. We look at the psychosocial aspect of health, the evidence of brain involvement, symptomatology, risk factors, psychosocial approach or interventions, and then the Ermelo psychiatric unit. Then we conclude. Next slide. Okay. It's roughly 7 months since the advent of COVID-19. It was in December 2019 when the World Health Organization reported the cluster of pneumonia cases in Wuhan, China, and the pathogen was identified as the novel coronavirus. In January 2020, WHO declared the outbreak as meeting criteria for public health emergency of international concern. It was in March when WHO actually declared COVID-19 as a pandemic. And after its declarance, it was actually noticed that this was an unprecedented situation and most countries were unprepared for its emergence. And then there was a lot of chaos in most countries. Then the clinical presentation of the COVID-19 was mostly physical. Therefore, most countries began with preparations, but mostly to accommodate management of patients with physical problems. So the virus is associated with high infectivity and fatality rates, and this actually led to serious psychosocial challenges. So the psychosocial effects that the virus had actually led to the emergence are as follows. The mass fear, so almost everyone was scared. And the second thing was the economic burden and the financial stress that or financial losses or financial stress that the countries had to actually endure. And then with that in place, there were strategies that were put in place to curb the spread of the virus. And those as well led to some effects or manifestations, the psychosocial manifestation or neuropsychiatric manifestations. This includes the lockdown, the traveling prohibitions, sometimes even not taking your alcohol and your cigarettes. Actually, those led to some challenges to the population at large, to many communities. Next slide. Oh, yes. Okay. So then this led to me to think, okay, you know, health sometimes is considered as health because people look at it as a physical problem. So I actually thought, let me just put this through to say, do we have the psychosocial aspect of health? WHO in 1948, they defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And they came up with some clarifications in 1986. They thought that people would not understand clearly what it means. They said it's a resource of everyday life, not the objective of living. It is a positive concept emphasizing social and personal resources, as well as physical capacities. So researchers in the Lancet, 2009, they defined health as the ability of the body to adapt to new threats and infirmities. With the advent of COVID-19, there was some uncertainty and unpreparedness, and that led to sudden life change. And the question was, when we look at the definition from the researchers in Lancet, it talks about the adaptation to threats and infirmity. Question becomes that could everyone adapt to this situation, which was a state of emergency? And that was still a question to be answered, as actually none of the symptoms that were prevailing in the beginning were not necessarily the psychosocial or neuropsychiatric or psychological manifestations. As I mentioned, usually there were the physical ones. And most people or most countries prepared for physical challenges. Next slide, please. Oh, okay. So the question arises, can we confirm that the brain is involved with COVID-19? Looking at COVID-19, usually we thought is the infection of the respiratory system, but could it involve the brain? there were some few studies that I looked into, and Butler et al., these were the group of researchers who actually said there was some emerging evidence of neurological and psychiatric manifestations and complications. So Talbot and colleagues, this was a preprint document, meaning that it was not, there was no peer review with this document. But I think it was very interesting for me that to see this. They did find that from the 44,000 patients without prior psychiatric history, there was an increased incidence of clinical psychiatric disorder 3 months after the onset of infection. So that actually brought a question to say, was it because these people who actually showed the manifestations, psychiatric manifestations, did they have pre-morbid psychiatric disorders, or was it that they just developed the illness? And therefore it brings forth the factor of, if they did not actually a prior psychiatric history, could it be that there are factors that actually were involved that actually led to these patients to develop this psychiatric manifestation? That is still probably not known currently. The research is still ongoing, and therefore it is a call as well for our department or our province to actually look into it, that we start actually following up. We do a longitudinal study to look into these psychiatric manifestations of these patients. And they actually found out the probability of those without a prior history, psychiatric history, it was about 5.8, which I thought it was really significant. And then those patients with pre-existing conditions, actually 65% of those patients developed psychiatric disorders. And the next study that I looked into was the study by the researchers at University College London. They actually conducted a study on 43 patients, and 29 of those, they were positive for COVID-19, and the 8 of them were having a diagnosis of probable COVID-19, and 6 of them, they had a diagnosis of possible COVID-19 according to WHO regulations or WHO regulations. So in their findings, they found out that 10 of those patients had developed encephalopathies with delirium, and 12 of the patients developed the inflammatory syndromes in the CNS, while 8 of those developed ischemic strokes, and 8 of those developed peripheral neurological disorders. And therefore, it was actually realized that all of these patients, when they actually tapped their cerebrospinal fluid, there was no virus that was picked up in their cerebrospinal fluid, which actually made them to come to a conclusion that probably the virus is actually causing the neurological syndromes or the neuropsychiatric syndromes through an indirect process, which could be due to immunological response that they were actually having, experiencing the immunity response against the virus, which actually affected the brain. The study could not ascertain the long-term neurological and neuropsychological consequences of the pandemic. As we notice, it is still ongoing. Therefore, we cannot completely exclude that these long-term manifestations or consequences will not actually develop. Okay. So when they looked at that, they noticed that the pathophysiology is not fully understood, but they actually thought it was just due to the immune response to the virus. But there was actually clear link between the brain inflammation and the mental health disorder. So from physiology that we have learned, you know, when the brain is inflamed, or the prolonged inflammation of the brain lead to the damage to the tissue, then the vulnerability to mental disorders. So most or all of the mental disorders have been actually shown to be associated with brain inflammation, which actually led to the conclusion that somehow there is some brain inflammation that continues even after the virus, the symptoms, physical symptoms had subsided. So it means it is very imperative and very important for the health workers to actually continue to assess patients for these neurological and psychological manifestations in their patients, which as well, it is important that as the healthcare providers, we also need to be aware of such circumstances, because this could be one of those that could happen, and it can be prolonged and lead to chronic disorders, psychiatric disorders. Okay, what are the risk factors to the development of these disorders or these sequelae? The probability to develop the chronic disorder is still uncertain. As I said, and I mentioned again, we need to actually start researching on this. We need a longitudinal study to actually check what is really happening and follow up patients who were actually diagnosed with COVID-19 to find out whether these patients will actually develop those features, or they will have developed that sequelae, and how long will it progress? Will it need further treatment or not? Or is it temporary? Is it short-lived? That is really very important. And I think Dr. Mawela is going to be assisting us with that. So one other risk factors that was actually identified was the pre-existing psychiatric disorders. So patients with pre-existing psychiatric disorders, they were more likely to develop psychiatric sequelae of COVID, especially, or some will relapse because of the COVID, and therefore it was identified that this was a risk factor to develop these manifestations. Healthcare workers, these ones, Dr. Squale? Hello? Sorry. Can everyone hear me?
Yes, we can hear you.
Yes, we can hear you, Doc. Continue.
All right.
Yes, we can hear you.
Yeah. So the healthcare workers, it was identified that the healthcare workers who actually cared for patients with Ebola and the Spanish flu, they actually developed post-traumatic stress disorder and depression after they cared for their patients. And therefore, it was identified that being a healthcare worker in these circumstances, this is probably due to workload, sometimes the uncertainty of provision of the PPEs or protective gears, that would lead to the healthcare workers being unsure of their future, whether they will leave or not. And therefore, it creates a lot of anxiety among them, and therefore, they are more vulnerable to develop these disorders. And the elderly, also that was shown to be a risk factors, but this was due to the fact that these are the patients usually who would have either conditions like dementia. And then these patients as well were more likely to develop neuropsychiatric disorders. Coming to symptomatology, the symptoms that actually were identified, there were psychiatric manifestations like anxiety, panic, obsessive behaviors, depression, paranoia, post-traumatic stress disorder. With obsessive behaviors, you know that we almost always clean our hands. We are actually afraid to go closer to our relatives, closer to people that are related to us, to the extent where at times I was asking myself, should I go close to my wife during the lockdown or during the isolation? You know, you ask yourself such questions. So this actually ended up leading to obsessive behaviors in individuals and communities. So, and the adverse psychological outcomes, usually the burnout, it was seen in the healthcare providers, the fear of transmitting the virus, a feeling of incompatibility. You feel you don't fit anymore in your colleague group per se, and the increased substance dependence. So I know during lockdown, usually we'll say substances were not sold, but people had ways of actually reaching those. So increase in substance dependence was another thing that was really going up as they actually assessed the patients. And some claimed that there was some brain fog where somebody is unable to actually clearly process information. They will be slow to understand things. They will be slow to do things, and they will even have trouble focusing on everyday tasks. You'll find a doctor, a nurse is struggling to actually put a drip on a patient that they are usually able to actually conduct. So that was another thing that they actually considered. And this was in keeping with the inflammation of the brain. When the brain is inflamed, most of the time you find that people will actually develop some brain fog. So this was a symptomatology that was really critical and very important that we actually look for, because a person may not come with anxiety, with panic. They may not come with, you know, burnout syndrome, but they may just say, Doc, I struggle that, you know, these days I can't concentrate very well. I tend to take very long time to finish my work. And I've noticed that it was after I was infected with the virus. So those are the patients that we need to actually look out for, so that at least we can pick up those symptoms immediately and be able to treat them. I think as well, as we have, you know, the symptomatology that the WHO has put down for us to follow and diagnose the physical symptoms for patients with COVID-19. It is a call for us psychiatrists, psychologists, social workers to come together and actually come with a tool that will help our institutions to actually pick up some of these symptoms, so that, you know, even a lay person can be able to assist or find or identify these symptoms and refer the person appropriately for help. Okay, in the symptomatology, I put protective measures. I think this as well fueled the development of the symptoms as it impacted on the patient's lifestyle. As I mentioned, the lockdown restrictions, which were good, I must say, But what I'm trying to say is that it actually made people now, they are locked in their houses. Some actually don't like being with their families, which actually is a positive thing, but somehow you find that some they want to be out there. And that actually led to more of the symptoms developing in most of the people who actually were infected with the virus. And actually not only those who were infected with the virus, but also those who were not infected, but they had some associations with patients that were infected. And the role of social media. This one, social media, we are in the time of technology. Social media is a good thing. Get me right, I'm not saying it's a bad thing, but it actually fueled, you know, the circumstances, the fear, the anxiety among people, because there was a lot of information. They call it infodemic process. So most people, they got a lot of information, some of the information that is unfounded, and therefore that caused anxiety and fear. So that is why I put all this under symptomatology. Okay, so the question is, what do we do? You can see on the screen, we have a man who is actually carrying a rock. I think it's way more than his size. It is really very imperative to understand that we need to actually identify the things that we are carrying. Most of the time, most people say we should be able to just make these things appear. We should pull ourselves together. We should be able to be resilient to mental issues. And therefore, most people are likely not to even talk to anybody or inform anybody about their situation, especially the healthcare workers. The worst patient that one can have is a healthcare worker, because most of the time we take some of the symptoms that we experience very light, and we do not actually consult or talk to anybody. We just think it will fade away. We actually most of the time think we are stronger, but this can actually crumble you down. You can imagine this man, this big rock being on top of him. So coming to the interventions, according to the South African Depression and Anxiety Group, the SADC, it claims that generally 16% of people who suffers from mental illness receive treatment. And according to Lancet, the Lancet in 2018, they actually said that, you know, a proportion of Africans who receive treatment for mental health problems is extremely low. And in Africa, between 2000 and 2015, the population increased by about 49%. And the number of years lost to disability as a result of mental illness and substance use disorder increased by 52%. You can see the importance of somebody consulting or seeking help when they have mental health issues. But most are more likely not to go for intervention, probably because it is associated with the stigma. So in the psychosocial interventions for the patients, this is where most of we need to actually destigmatize the disease. This in the patients, let's say patients who are admitted to the hospital, we should address these patients by name. In my hospital, Witbank Hospital, we have a ward. In the beginning, we used to actually call it COVID ward, but now we call it COVID-20 while busy trying to get a name for it, because this usually most of the time stigmatize the disease and stigmatize the disease to the extent where patients who come from the ward, they are seen as people who should be isolated, put aside, even after they got intervention and the symptoms subsided. I do not forget the story of one person that I know. Actually, one time when the disease actually emerged in South Africa, the person was like, yo, they are saying what 20 is the COVID ward. I am no longer going to park my car there. So probably the person was thinking by just parking the car next to that ward, she was going to just contract the illness. So we need to try and destigmatize this illness. We need
Dr. Ngwana, yes, you may continue, but please note the time. You are left with 2 minutes or so for your presentation, so that we can give enough time for engagements. Thank you.
Okay. All right. So we should allow interaction for family and friends via phones and video calls. And we need to alleviate fear and anxiety by sharing success stories about people who recover from the disease. And then we need frequent assessment for development of mental health issues in these patients. And we need to offer individual counseling and applying psychological techniques like CBT. Those patients who need referral to psychology need to be referred so that they can get counseling and cognitive behavior therapy. And we need to allow patients or inform patients that they need to take care of their physical and mental health by exercising and eating nutritious food. And then psychosocial intervention for healthcare providers. The providers need support, that is supply of enough PPEs, words of encouragement. I once came up with a acronym, CHAMP. So we need to actually encourage our workers, allow enough rest at work, identify own personal feelings, and seek help when necessary. We need to form clear channels on accessing psychosocial support teams, that is for counseling and psychotherapy, and continue education about the disease, which alleviate fear and anxiety. Is done very well in Witbank, and we need to destigmatize the illness. And then other coping mechanisms, we need to stay connected to family, friends, and communities in creative ways. And then we need to manage challenging emotions with acceptance and mindfulness, relaxation, soothing, and pleasurable activities. We need to avoid substance use and stop ruminating or having constant worry. We need physical activity, healthy eating, and we need to practice sleep hygiene. So another part is attending to gaps in the provision of mental health treatment in various facilities. It's very imperative. So concluding my presentation, I looked at the Ermelo Psychiatric Unit. We assessed the unit on the 28th of July this year. There were some renovations that were done, but the challenge was that the hospital could not accept the handover of the unit from the contractors, but areas of possible use were identified, though extra work is required. And the province need to try and work on psychiatry infrastructure. This I will submit to Dr. Mawela and the team so that they can see what needs to be done. Thank you.
Thank you. Thank you so much, Dr. Ngwane, for such a wonderful presentation. Unfortunately, due to time constraints, maybe we'll need a second round of these psychosocial impacts, you know. Interesting, I never knew that there's brain involvement with COVID. You know, just last week, I realized that there's also bowel involvement or intestine involvement when Dr. Ngwane was presenting surgical challenges in COVID. So this just shows us as healthcare workers that there's still much we need to learn, you know. So this disease is with us for quite some time. Colleagues, without further any waste of time, I'll call upon Dr. Mweleken Situnza. I'll just reintroduce again for the sake of those who attended late quickly so that she can give 1 or 2 minutes comments. She is a principal clinical psychology for both public institution and in private practice. She has been practicing as a clinical psychologist for more than 10 years. She was conferred a doctoral degree in psychology, PhD, and also awarded a master's degree in psychology. And she obtained a Bachelor of Psychology from UNITRA. She's interested in health psychology, medical psychology, and she's currently embarking on COVID-19 related research. Dr. Situnza, please. Can you give us your...
Good afternoon, colleagues. Thank you very much, Dr. Sikole, for introducing me. And I would like to say thank you very much to Dr. Nkwane. I think the presentation was really good. And I think it was very informative. I learned so much. I'm really grateful that I really attended this. I think I'll start looking at mental health with COVID patients now quite differently as well. Because I think for me, I'm going to speak specifically on the practice in terms of the experience that we have in practice with the patients. What I've identified is that we get 2 groups of patients, right? The ones that isolate at home, and then we get those that are admitted in hospital. And what I noted is the way they respond, that they seem to respond differently. Those in hospital are quite isolated. They go into a lot of depression. They experience a lot of anxiety. And some of them, because they witness other patients dying, it ends up making it even more real for them. And the anxiety, the depression ends up prolonging their recovery process. And when we talk of the stigma, as Dr. Nkwane mentioned, the stigma, especially in the beginning, was a big problem for those patients admitted in hospital, because after they recover, because of the stigma, the patients were really feeling neglected and rejected, because the family members were scared to even to come and fetch them in the hospital. So which resulted in a lot of psychological conflict for these patients, that they felt the way that they felt. And what I've also observed is that the patients that recover at home, who isolate at home, they kind of, they experience it differently, because they sort of feel that there's a support that they receive from their family members. However, even though they receive support, they still go through anxiety, because they end up reading a lot of information. I think, Dr. Nkwane, you touched on social media, you know, the way people end up reading so much information. They end up bombarding themselves with so much information. And some of them, they speak often of the crash week, where all of them speak about this anxiety, that they wait anxiously with anticipation for that week where everything is just gonna stop. And that keeps them panicking most of the time. So I found that that was quite interesting for me. And some of the patients that were admitted in hospital, they often present with some of the post-traumatic symptoms and obsessive compulsive tendencies post, even the ones that isolate at home as well, they tend to experience the obsessive compulsive symptoms. And then we've also noted that they end up, there's behavior change that we observe. I think Dr. Nkwana also mentioned that, where there's vigilant hand washing, avoidance of crowds, avoidance of people who are not wearing masks, they become extra vigilant and wary. And then, because we also deal with adolescents, we also deal with adults and children that test positive for COVID, I found that the adolescents seems to be much calmer in actually coping and dealing with the COVID symptoms and even the psychological impact compared to the adults, which I think it's something maybe we can invest in research and find out what is happening. And also, as Dr. Nkwane mentioned, about psychological vulnerability and patients who have been previously diagnosed with mental conditions more vulnerable to have more conditions, mental health conditions. I've found that most of these patients, they struggle, especially the ones that have had depression before, who are psychologically vulnerable. They struggle to cope compared to those patients who haven't had any mental conditions before. So what has been very important and interesting for me is that as the patients get diagnosed, they need support. And most of my patients that got diagnosed, they immediately informed me. I think providing the patients with brief supportive sessions telephonically, because as psychologists, we're not allowed to go into the COVID wards. We're not allowed to see, to have face-to-face with COVID patients. So it's very important for us to provide those telephonic sessions to them. It's very important for us to provide video conferencing to them, because that also assists them to feel the support and also to feel that they can be able to talk to somebody who's listening without judgment. It's very important, Dr. Nkwane, you mentioned assessment tool. I think as I work with the patients, I've realized that it's important for us to have mental health practitioners involved from the first day that the patient is diagnosed with COVID, because that's where we come in. So in order to assist these patients and in order to assess and monitor gradually the presentation, especially if there are any symptoms or mental health symptoms that we identify with the patient early so that they can be managed early. And what I've observed also is that most patients who are psychologically resilient, it actually helps. A positive mindset for this patient really helps, and also enhanced social support serve as a protective factor for the patients. And when it comes to interventions, Dr. Nkwane mentioned CBT. I know some of my colleagues will probably think, yeah, psychiatrists do love CBT, but it really worked with some of the patients because cognitive reconstruction is needed at that stage, because they are so overwhelmed and so anxious, they hopeless. So you need to constantly change their mindset so that they can have a positive mindset. And I found that breathing exercises, relaxation exercises, it actually helps. It even actually helps them with the breathing as they often do it, because some of them, they experience difficulties with breathing. So I found that it actually helps them a lot with that. So I think what we spoke about in terms of the social media, it also evokes a lot of anxiety for most people. When we spoke about the stigma is a real concern at this stage, because some patients prolong getting help because of the fear of being judged, because of the fear of being discriminated. And some of the patients that have tested positive, the first thing they worry about when they have to get out of isolation is how people are going to treat me, because everyone is pointing to that house, that someone in that house, you know, that house that has COVID. So it makes it very difficult, even going back to the work environment. For some of the healthcare practitioners, it has been very difficult because of the fear of the stigma, which I find that it is really not necessary. And I think we can do something about it and really work on destigmatizing the COVID-19. Thank you very much.
Oh, wow, that was mouthful. Thank you so much, Dr. Sechunsa. And I think the key word there is to destigmatize COVID-19 patients. And, you know, I've said it to colleagues before, COVID-19, it's a painful disease. You know, when you're sick, you need your family to come see you, your friends to come see you. You need those visits, whether admitted or not. But this is the disease where you have no one but yourself and the social medias and all that. You know, I think you've touched on everything. We really appreciate your comment. Thank you so much. Dr. Nkwane, can you please unshare your presentation? And the speakers following, please, when you speak, can you show your face? Colleagues are crying. They hear the voice, but they want to put the voice to the face. Giving comment following you is Dr. Kalane Dikobe. who completed in 1999 MPCHB, and then MET studies, Masters in Psychiatry in 2006, University of Pretoria. She headed the Department of Psychiatry at Steve Biko Academic Hospital, and then currently full-time in private practice. And she's passionate about psychoeducation, transcultural psychiatry. Dr. Dikobe Kalani, please.
Good evening. Yeah, I think I am unmuted, I hope. Thank you so much for the opportunity and the platform. My two previous colleagues, I think, have said a mouthful in terms of the psychiatric manifestation and affectation following COVID and during this pandemic. So I'll really speak to what we've been experiencing in private practice, because that's the space where I'm practicing, is that, you know, when this whole pandemic started, there was so much fear and anxiety attached to it. I mean, we all had to learn how to don and doff these horrible PPE. And when you are then called to go and see somebody in the so-called COVID ward or the red zone, and you have to go in as a psychiatrist to go and give counsel and instill hope in somebody who is already feeling very anxious and feeling very hopeless. And you come in and you're wearing this space suit. You know, we rely not only on our voices, but we rely on body language, eye contact, you know, a friendly smile. Now, suddenly, you can't use any of those communication tools. You only have your voice to rely on. It has been quite exceptionally difficult, but we have been trying. And what I then started doing in my private practice, because I found that instead of actually instilling hope in my patients, I was making them feel even more anxious. So I then took a conscious decision not to actually go into the COVID wards, but to rather do virtual consultations, virtual face-to-face consultations, which I found to be more effective, because at least there's no mask, you know, you can actually have eye-to-eye contact with the patient. So I found that has really helped a lot. And what we also have noticed, or I've noticed in my practice, is that a lot of my patients who had pre-existing diagnosed mental health issues like bipolar disorder or depression or anxiety disorders have been relapsing more frequently. And the relapse is actually fueled by the anxiety. Because if you're anxious, you have difficulty sleeping. If you don't sleep, your mind becomes fatigued, and so it becomes a vicious cycle. So we have been having a lot of relapses, not because of non-compliance on their medication, but only because of this added psychosocial stressor, which is COVID-19. Another trend that I've also picked up is that a lot of new diagnoses of anxiety disorders I'm actually picking up in my practice, where, because I do quite a lot of educational videos on social media, you find that patients will then identify with some of the symptoms that I've alluded to and would reach out, and they actually now start talking about what they've been experiencing since our president announced the lockdown and as the months have gone on. So there is definitely an increase in the diagnosis of anxiety disorders. I myself recently recovered from COVID-19. And like Dr. Ngwani said earlier, that healthcare workers are actually more vulnerable to developing psychiatric manifestations post the infection. And yes, I actually did experience this brain fog, you know, and the brain fog, I think it continued for another 2 to 3 weeks post my 14 days isolation. And yes, I can actually sit here, it'll be like a group AA meeting that, hi, I'm Lerato and I suffer from an anxiety disorder, because I've also now self-diagnosed, but then also went to see a colleague with an anxiety disorder. And it's more like PTSD symptoms where, you know, for me, my anxiety is actually about leaving my house. You know, because of that fear. If you see somebody walking around without a mask, you feel like you're going to have a panic attack. So it is very real. And for me, having gone through it, it has actually made my therapy with my patients so much more meaningful, because I'm able to put their minds at ease to say, you're not weird. This that you're going through, I myself have experienced, and it actually makes it more effective. And another thing I think also challenge that I've come across is a lot of our medications, a lot of the novel antipsychotics that we use do have a side effect of weight gain. And with weight gain will then come the syndrome X, you know, the high blood pressure, cholesterol, and diabetes. So, you know, although you try and encourage your patients to stay active, but because of the sedentary lifestyle that a lot of our patients with chronic mental illness lead, it does make them put them at higher risk of more severe illness. Also, patients who are on medications like clozapine, which we know to cause agranulocytosis, and without COVID itself, but the agranulocytosis will increase their chances of contracting pneumonia. So then it becomes sort of catch-22 situation. You know, do I discontinue the clozapine and risk the psychosis coming back, or do we continue with the clozapine and then monitor the white blood cells, you know, more closely? So it does become a bit of a conundrum in practice. And then maybe also in closing, what I've noticed also is that patients with mental health issues or a history of mental illness, there's a lot of stigma out there. And the stigma is not only societal, but also with healthcare workers. You know, if you, as somebody who's been diagnosed with schizophrenia or bipolar or an anxiety disorder, you go to your GP and you say, my GP, you know, I'm not feeling very well. My chest is closing up. You know, I've got all these symptoms of COVID. You know, the automatic negative response from that clinician would be, no, it's just your anxiety flaring up. You know, so a lot of our patients tend to not get tested as quickly as non-diagnosed patients. So a lot of them would then present later or be diagnosed later because of that pre-existing stigma of their mental illness. So yeah, that's my piece for this evening.
Thank you so much, Dr. Dikobe. Thank you. Yet again, another informative discussion. Colleagues, I think you all agree with me. I think if we talk psychosocial issues, it can take the whole day or a whole year or a whole month. I feel from my personal perspective, we need another session. Due to time constraints, we have to cut speakers, which is not fair, you know. But of importance is what you have mentioned, Dr. Kalan, is visual conference or visual consultations. To so many colleagues, especially in private practice, this has been approved and you can claim for it by regulators. So it is allowed, you know, especially if you've got anxiety in putting PPEs and all those things, especially if you are a recovered healthcare workers like Dr. Dikobe. And congratulations to you to have recovered, and we need you in the space. Thank you so much. I see two hands. I see Nomthandazo Zwane and Itumele Mpoloke. Let's start with Nomthandazo Zwane. I think she's the head of COVID unit in Witbank Hospital, a physician by qualification, and part of a COVID command lead in the province, and also reviewing files of deaths in the province. Dr. Nomthandazo Zwane.
Thank you very much. Thank you very much, Dr. Skole. Dr. Nkwane, Dr. Dikobe, Dr. Sentuse, this was very, very, very beautiful.
Dr. Zwane, you may need to move around. We can hardly hear you.
Hoping, Dr. Mawela, if it's possible for you to give us, especially the sisters in the COVID ward. Can you hear me? Can you hear me now? Hello?
Yes, thank you. Continue.
You can hear me. All right. Hear me. Dr. Scholar?
Yes, we can hear you, Dr. Zwane.
Okay, so I was saying I have been very concerned that in the near future there will be a second wave. This will be post the current COVID pandemic. And colleagues, I'm worried that this wave will be far worse than the COVID itself. I'm actually happy all of our speakers have hinted on this one, because this will be like a hurricane of chronic illnesses. Yes, we will have chronic respiratory disorders, chronic cardiac disorders, and we'll definitely be having chronic psychiatric disorders, the likes of PTSD, depression, as well as anxiety. I am very worried that as a country, I feel like we are not preparing ourselves to accommodate this coming storm. Because colleagues, if currently we think our OPDs are full now, wait until this tsunami hits. And I'm worried that, I know that currently the trend is actually going down, but this tsunami is going to be worse than what we're having now. That's why I really feel that our field hospitals, we need to proceed with field hospitals to accommodate this coming storm. With that being said, I'm also a survivor, a healthcare worker, and a survivor of COVID myself. So the main problem that I experienced the time I had COVID was the fact that I infected my husband. So after infecting my husband, I had guilt, a lot of guilt issues. Although I was very supportive, but I felt guilty that I've infected him. And I still feel like I still have guilt issues currently, and worry that what if I infect the rest of my family, like my child, for instance. So I would like to ask our panel of experts on how does one deal with such guilt issues? Thank you very much.
Thank you so much. Thank you so much for the input, very important inputs. Yes, we may have a research or a second wave. We need to prepare ourselves for that. Can I ask Itumeleng Poloken, also a psychologist at Witbank, to say a few words, and then we take a hand of Mary Mukete? Itumeleng, please. You may unmute your mic. Okay, we can move to Mary Mukete. We see your hands while Itumeleng is still struggling. Mary Mukete, we see your hands up.
Okay, okay, I'm Mary Mukete. Okay. Thank you very much, Doctor. I just wanted to pose a sort of a concern that I've discovered as a sort of an observation. I'm a nurse, and then working closely with the isolation site in Middelburg. What I've observed when we admit patients, especially the COVID-19 patients, there was a sort of a phenomenon that came from the community, and I was so interested, though it's painful, but I was so interested about it because we asked questions to say, we identify why the person needs to come to the isolation site from her household or his household, and then for us to say now they are being sort of segregated by their family members at household level, to say to an extent where some they were staying in the cars because of lack of knowledge from the family members. They were washing in their cars. They said they don't want to see them. There was even one whereby she was staying in the rooms they were renting. The other tenants were even gaining up against her to say you are COVID-19 positive now. Go out of our yard and all those things. So I was just so worried to say, but then okay, I understand that the underlying issue around this is that people don't have knowledge. But then now I was so interested to say, well, can it be like this, especially to the fellow human being, to say they tell them out to say go out if it's a household, go out if it's a room, go out if it's just whatever that the person says. So yeah, I had that issue when we were doing, especially 2 months back. So I'm just puzzled by that. Yes, thank you very much. Bye.
Oh, thank you so much. Sometimes we tend to forget communities, and as healthcare workers, when we discharge or send this patient home, either to self-isolate, quarantine, or even post-COVID, we forget about those issues. Itumeleng, quickly before we address these questions by the panel.
Okay, hi, can you hear me now?
We can hear you, thank you.
Okay, evening, and thank you for the opportunity. It is quite an informative panel, and it is also quite clear from what our participants have said, how the psychosocial impact of COVID is slowly eroding on the social connection or the social connectedness and the empathy that we have for each other. So I would like to actually give a word of encouragement to healthcare workers and community at large that, amidst the COVID, because we should not allow ourselves to be consumed by the fear and the paranoia and the anxiety, to not despair and to not lose hope. And that we should remember that all of us as healthcare workers, that we are stronger than we think. And that is a message that we actually can give to our patients and the community out there. And what we need to do is that first and foremost, you have to take care of yourself before you can take care of your patients and the community at large. And that is the message that we can also give the patients that we get to see. And that us as healthcare workers, we need to close the gap in providing psychosocial support that is so needed in our community and also in the environment and the space that we are finding ourselves in. And providing support, colleagues, it's actually not just for psychologists, but it is a responsibility of each and every one of us. And in the small spaces that we find ourselves, that you can give support in ways that you can. And that's all that I want to say for the evening.
Oh, thank you. Thank you so much. Dr. Dikobe, I think I agree with you in the sense that your non-verbal cues, we can clearly see them here in Itumeleng as a psychologist. You know what I mean? Thank you. Very valid points. We need to start with self-introspection before we can apply to our patients. You know, self-care and all those kind of things. I think a valid point. And a straightforward question, Dr. Dikobe, how do we deal with issues of guilt at home? As a healthcare worker, you infect your husband, you infect your family, like Dr. Nomthandazwane has said. How do we deal with it?
Yes, very, very true, because I remember when I was going through my entanglement with COVID-19, my greatest fear, my fear was not fearing for my own life. My fear was for that of my husband and my children, because I isolated at home and he chose to isolate with me to assist me, because, you know, anyone who's gone through this thing, you know that it saps you of energy. You cannot do anything for yourself, you know. So I think that the issue of fear and guilt is, again, it's that mental self-talk that you did not go out to Woolies and say, I am buying COVID-19. You know, you contracted this illness in the line of duty, and your family knows that this is your calling, this is your passion. And you know, if you know in your heart of hearts that you were following all the preventative protocols, you know, don't feel guilty, because it was not out of your own doing, you know, but because we are human, you fear for the lives of your family members, especially if they are, you know, family members that are living with chronic illnesses, or there are elderly family members in the house. But really, we should not be so hard on ourselves. We are only human, and we're susceptible to human conditions.
Thank you very much. Not only a calling or anything, but this is also our bread and butter. You stop working, you suffer, you know. Straight to Dr. Mweleke and Situnza, how do you deal with issues of segregation post-de-isolation or post-quarantine or post-discharge?
Thank you very much, Dr. Sikole. I think it's a battle. I think Dr. Dikobe just alluded to that you know what, it's a psychological battle that one goes through, because you find people saying, I had more of a psychological battle than I did dealing with the physical symptoms. So it takes a lot, which is why it's important for one to undergo therapy. The guilt that we are talking about, it's real. Even the patients that have survived, they have the survival guilt. Not only the guilt feelings of infecting others, but also the fact that other people are dying, you are surviving. So it has a lot of...
Excuse me, Dr. Moregen.
Oh, okay. I wasn't ready for this, but it's okay. All right. Hi, colleagues. So I think that is very frustrating for the patient. So it's very important. Remember, when you have such a condition, so much is going on. It touches on other areas of your life as well, your other past experiences. So they end up contributing to how you're going to cope with it. So it's very important that after you experience that, after isolation, consult, get psychological interventions to deal with everything that you've been going through, because it's a psychological toll. It's exhausting, it's draining. We've been there, we know it.
Thank you so much. This one is from the chat. Dr. Nkwani, you seem to be admitting quite a lot of patients in the province with COVID-19. And bear in mind that your patients have got psychosocial illness with the issues of difficulties in advising them to wear a mask or to have a social distance. How do you deal with that, especially in a setting where there are PUIs?
Okay, yeah, it's really extremely difficult, Dr. Scholar. Thank you for giving me that question. It's extremely challenging because our patients, most of them, you find that they do not understand actually the fact that they should social distance. You know, our setting as well allow that, because in a hospital, in the unit where I am in Witbank, where they eat, it's actually an area where everybody sits there. And then they have to go out for their activities. In psychiatry and psychology, unfortunately, patients need to interact. It's part of their management. So it's really very difficult, though we are trying to educate them every morning. Our nurses are actually vigilant and very good. Every morning they teach our patients about face masks, and they supply them with face masks. Though some will put them on the forehead, some on the nose, some even at the back of the head, but some would actually put them correctly, and actually they will follow the regulations. So social distancing is still a challenge. That is why it is very imperative and very important that we have units that will actually accommodate patients who are infected or the PUIs, so that at least we can deal with those patients separately. And if it was possible as well, and the infrastructure was allowing, that we could actually even separate those who are infected and without psychiatric manifestations, that they could be aside, and those with a positive test and they have psychiatric problems during that event, that they can be separate. And I think their management will be smoother and better if we can actually allow that, which is my call to my bosses to say, please help. I'm here, I need help. Okay, so that patients can be cared properly. Thank you.
Thank you so much, Dr. Nkwani. Dr. Mawela, don't kill me. Just one question from the chat that have been sent privately. I know the meeting is overdue, but this is quite interesting. I think we'll have a follow-up to this meeting. Thank you for that. From what I hear from you, Dr. Nkwani, is the issues of infrastructure in the province. And I believe there are high people in the meeting, they are listening. They'll make sure that it happens. Dr. Situnsa and Dr. Dikobe, this one is addressed to you. They say, how do you address a family if you've got COVID-19? How do you end up telling them? In one of the previous discussions, I had a panel of healthcare workers who have recovered from the COVID-19 disease, and a young guy who had fears in telling the mother that he's got COVID-19. So he wants to know, how do you go about it so we can educate the other ones? That's number one. Number two, it's we have seen an increase. It's not me, it's what is being sent to me to ask. We have seen an increase in divorce during lockdowns and isolation. What is your take on that? I'll start with Dr. Dikobe before Dr. Situnsa.
I think on the issue of how do you tell the family, I'll give you an example of a group of patients of mine who got infected with COVID-19 while admitted in our facility due to an outbreak. It was very difficult, and I took it upon myself to be the one that, I had actually had them in a group setting, talking to them, checking who they live with at home and how we inform relatives. And those that found it difficult to do so, as their mental health care provider, I offered my assistance in breaking the news and then preparing for their homecoming on how everyone should sort of navigate their way around this thing. And maybe then the second point, I'll leave it to Dr. Situnza about the divorce, but I think I have an idea why, but I'll leave it to her.
Dr. Situnza, can you help us?
Yeah, let me try. With everything that has happened, especially when we knew about COVID-19, lockdown was introduced, right? So a lot of companies had to close and people had to work from home. So what has been happening is that, you see your husband or wife, in the afternoons only. Now you are supposed to be in each other's faces all the time. And you get to understand each other's habits, even the ones that you were not fond of or you didn't even know about. So it became so real for most people that, unfortunately, even the issues that were underlying were brought up to the surface, because now there was no running away from them. You can't go and drink. You can't go out with your friends to escape what is happening in the house. You have to face it. Hence, we saw also gender-based violence in the increase, as well as the divorce. Right now, we are dealing with that a lot in therapy, because after the lockdown, a lot of couples are really having it hard at the moment.
But that pelad, it was too much.
All right, colleagues, thank you. Thank you so much. I don't see any further hands, and I don't have any private questions that have been sent to me. What I've gathered from this meeting is that these psychosocial issues, they really impact us as healthcare workers dealing with patients, or as healthcare workers being infected ourselves. It affects our patients in terms of management. There is no screening tool for psychiatric patients. There is no proper infrastructure for admission of these patients. And then we need a psychosocial team, which include a group of multidisciplinary approach from Dr. Oloram. Thank you so much for such inputs. Colleagues, let not these meetings be for our own self. Let's go out there and share the information with colleagues, families, and friends who could not attend this kind of forums. And in closing, I'm giving back to the host. I'll start with Dr. Nkwane, followed by Dr. Situnza and Dr. Dikobe, just to give us a 2-second take-home message to the audience and to the panel. Dr. Nkwane, quickly, your take-home message. Please unmute your mic.
Sorry. Thank you, Dr. Skole. My take-home message is that education is the key. And remember my encouragement message. You are a champ as a healthcare provider. You are a champ next to a COVID-19 patient. You are a champ next to your relative who has been infected. Please encourage them, tell them these good ways that they are champs because they can make it. Thank you.
Dr. Nkwane, can you just in 2 seconds and define for us this mnemonic of yours? What does champ mean or stands for? C for?
Chosen.
Chosen. H?
Healthy.
Healthy. The A?
Able.
Able. M?
Mission.
Mission. And the P?
Passion.
Oh, thank you so much. Thank you. Thank you. Dr. Dikobe, your word of encouragement or in closing?
Right. So this virus has been very cruel. It has actually separated us from our social support systems. So even though we cannot physically be with each other, but let us keep on checking on each other. Just that phone call, that WhatsApp or text message, and you must ask, emotion-based questions, not how's it, but how are you? You know, I know you've had a long day. How are you coping with it? How are you dealing with the multiple losses? And if we can do that for each other, honestly, I think we can beat this horrible pandemic.
Thank you. Thank you so much. Yes, let's not just say how's it. I learned that today. Dr. Situnza.
Thank you very much for including me in this session. I think it was a very informative session. I'm very grateful for it. But what I'd like to say to especially healthcare workers, you know, we take care of everyone else. Please take care of yourself. You know, self-care is important. Take care of yourself and learn to breathe. We are on the run. It's time to take it easy. I understand the circumstances are not allowing, but let's try and take it easy and take care of ourselves.
I'm not sure what was next. Dr. Segole? Yes, I think, yeah. So just to say thank you, everyone, for attending, but importantly to our panel for sharing your knowledge. I'm a person who always looks out for questions, you know, that need to be answered. So I think we are going to probably bring you back 6 to 10 times in the next few months, because as you were sharing, you know, the knowledge, giving us advice, I've noted few things. For example, how to prevent a mental health outbreak, which we think is going to happen. You know, the second wave might not be COVID in its current form as a virus, but it's possible that we are going to have a need to respond to mental health issues. I wrote down how to heal a broken community, because people have buried their loved ones without seeing them. People have buried their loved ones, you know, alone. They were not allowed, you know, to see them, to grieve, you know. People have experienced, you know, a number of painful experiences in the last 5 to 6 months. People have lost their jobs. We have seen the increase, you know, in gender-based violence. So I think the next session, we probably need to look at what needs to be done. I think today we have unpacked in detail, you know, the implications, what we foresee happening, what we are seeing happening currently. We now need to look at, in terms of health worker support, whether we embrace, you know, I like where we discussed issues of virtual consultations. How do we embrace technology so that we can provide large-scale mental health or psychosocial support to communities and health workers? So thank you very much for that. For those who are still here, just to say that next week we are going to look at anesthesia challenges with COVID-19. We have Prof. Madlala, Dr. Mapolo, and Dr. Gekana representing SMU University, University of Pretoria, and also Witbank. So I think it's going to be another exciting event. Please do type in your full names, email, and your CPD council registration so that we can know who to allocate CPDs for. Overall, just to say thank you, and we look forward to the next session. Dr. Segole, for one reason or the other, I think he ran out of data or something like that.
I'm back.
We can just blame ESCOM. Yes, so thank you very much, colleagues, and we appreciate your support, and we hope that we'll continue to empower you. Enjoy your evenings, and good luck to Mamelodi Sundowns today as we win the league. Thank you. Bye.
Thank you. Thank you so much.
Thank you.
Bye.
Bye.
Bye. Thank you, guys.
Yeah, bye-bye.
You continue to type in your full names, emails, and your council registration. For the panel, I think we have your contacts.
Oh, okay. So I don't need to do this. Okay, sure.
No, we will liaise with you. Thanks.
Thank you, guys. Good night.
Bye.
Bye. Good night.
Good night.
Yes.
Bye, everyone.
Bye, Dr. Stunzi.
Satchele Hlophe. Bye. Let's see who else.
Why can't I leave?
Sister Tuli, Dr. Ross, Tembi, Lavisa, everyone. Mr. Apane. Yes. All right. That's it for today.